Hello again. Let us now continue with part 2 of electrolyte disorders related to neuromuscular and cognitive dysfunction. Now we will deal with serum potassium disorders in relation to the neuromuscular and cognitive dysfunction. Actually, most of the potassium in the body is resident inside the cell, where the concentration of potassium in the intracellular fluid is nearly 140 milliequivalent or millimole per liter. And taking in consideration that the size of the intracellular fluid volume is around 28 liters, then the intracellular potassium is nearly 4,000 millimole, while the concentration of potassium in the ECF is nearly 4 in that 14 liter of the ECF, giving nearly 60 millimole as the amount of potassium outside the cell in the ECF. And every day in our diet, we are exposed to something like 100 milliequivalent per day of potassium intake. And this will be excreted mainly through the kidney, 92 milliequivalent, and a very small part is just excreted in the feces, 8 milliequivalent per day, giving the 100 milliequivalent per day. Actually, the kidney can change the amount of potassium excreted daily according to the intake. If the intake is too much, the kidney can excrete more. If the intake is too little, the kidney can excrete less. So as to keep the serum potassium and intracellular potassium in a homeostasis and in a balance that keeps the body going. And in the intracellular potassium, mainly in the muscle, nearly 3,000, and some in the liver, and some in the RBCs, and in the other tissue. Hypokalemia can be seen as either due to decreased total body potassium, so there is removal of potassium from the body without replenishing the loss, or the total body potassium is the same, but there is some intracellular shift of potassium, so the potassium goes from outside the cell to the inside the cell, and there is a category of cause of hypokalemia called spurious hypokalemia. And this is met with when there is extreme leukocytosis. So the sample outside the body, the leukocytes in excess would eat the potassium or engulf the potassium from the ECF, causing the ECF to be depleted of potassium. This is just outside the body. So inside the body, there is no problem. So the lab will tell you that the serum contains less potassium, so hypokalemia, but the patient wouldn't have any symptoms and signs related to the hypokalemia. Intracellular shift is due to some hormonal problems like beta-2 adrenergic agonists or insulin therapy, or some drugs like the beta-2 agonists, salbutamol, terbutaline, adrenaline. Any sympathomimetic would do that, especially the beta stimulant. Theophylline, and barium. Treatment of digitalis toxicity with digibind and exogenous glucose and or insulin. But the exogenous glucose would do hypokalemia only if the patient can secrete insulin endogenously. So as it disposes the glucose off, entering it, transferring it inside the cell, so as it transfers potassium with it. Or insulin therapy because it does the same. Some other causes of intracellular shift like refeeding syndrome, when there is prolonged fasting and the patient is refed back again. A condition called hypokalemic periodic paralysis, and treatment of megaloblastic anemia, so as the cell is proliferating back again and it eats some potassium from the ECF, which may cause hypokalemia. The decrease in total body potassium occurs in severely prolonged inadequate intake. So there is some obligatory loss of potassium in the stool and in the sweat, while the patient is not replenishing the potassium by increasing the intake, or when there is renal loss or extra renal loss, like in the GIT. The extra renal loss occurs with overt diarrhea, copious drainage from fistula, villus adenoma, intractable vomiting, or questionably loss in perspiration, because the amount lost in perspiration is very minimal actually. But if somebody is in drenching sweating for a long time, then he might lose a bit of potassium every now and then. And if he is not replenishing it by oral intake, then he will have hypokalemia. Also, those with anorexia nervosa or tea and toast diet wouldn't intake sufficient potassium to keep the serum potassium homeostasis. Renal loss occurs with mineralocorticoid or glucocorticoid excess because these hormones helps the removal of potassium from the body, decrease the reabsorption of potassium from the kidney. Bartter and Gitelman syndromes are two syndromes associated with loss of sodium and maybe potassium from the kidney, from the renal tubules, associated with metabolic alkalosis. Thiazide, loop, and osmotic diuretics all increase the clearance of potassium from the body. Renal tubular acidosis, type 1, type 2, type 3, but type 4 is a hyperkalemic type, so be aware of that. Type 4 renal tubular acidosis is not associated with hypokalemia, but the other types, type 1 and 2 and 3, which is a combination of 1 and 2, is associated with decreased tubular reabsorption of potassium and increased potassium output to urine with hypokalemia. Chronic metabolic alkalosis helps the loss of potassium, and Liddle syndrome, it's another syndrome in the renal tubules associated with hypokalemia, metabolic alkalosis, but here there is hypertension and some sodium retention. Acute leukemia and erythrosigmoidostomy are also associated with renal loss of potassium. One of the important manifestations of hypokalemia, which occurs fairly early before many other manifestations, is the development of ECG changes peculiar to hypokalemia. The most prominent feature of that is the development of U wave, then flattening of the T wave, and even depression. Then the U wave become very prominent, so as it occupy the T and U. Then you can measure the QT interval and you think it is prolonged because you can misinterpret U as T, and if you measure QU interval and you think it is QT, you find it prolonged than normal, and you might start treating the patient as a long QT interval patient. Most of the manifestations of hypokalemia comes from cardiac problem, like abnormal ECG, as I said, and there will be some atrial and ventricular arrhythmia, can lead sometimes to AF or occasionally VF, and it predisposes to digoxin toxicity. So the patient runs with digoxin toxicity manifestation very early if he has got hypokalemia. Some hemodynamic changes like variable blood pressure up and down every now and then, and decreased pressure response to angiotensin II with some hypotension. Importantly, there are a lot of neuromuscular problem related to hypokalemia. The most important is GIT, especially in children when they might develop ileus or constipation. Also, adults can do that. And weakness of the skeletal muscle or manifestation like myopathy. And if it is severe, there can be paralysis or even rhabdomyolysis. And in patients who have been with severe hypokalemia for some time, they can develop respiratory paralysis and respiratory problems. Hypokalemia is also associated with decreased renin and aldosterone secretion and decreased insulin secretion, so as they might develop diabetes and there might be increased prostaglandins. The effects of hypokalemia on the kidney is very peculiar. There is decreased GFR and renal blood flow, but there is what we call hypokalemic diabetes. It's not diabetes mellitus, but it is polyuria, polydipsia, and concentration defect in urine, and there is stimulation of thirst. So there is resistance to the antidiuretic hormone and development of nephrogenic diabetes insipidus. Actually, two important electrolytes in this order is associated with that. This is hypokalemia, and the second one is hypercalcemia. Increased renal ammonia production, so it helps the development of hepatic encephalopathy with the use of some diuretic. Hypokalemia is also associated with renal sodium retention and renal chloride wasting and renal contribution to the development of metabolic alkalosis. So the neuromuscular is very important and can be presenting manifestations of occasionally hypokalemia. EC extracellular redistribution of potassium occurs in cases of this is now hyperkalemia. As hyperkalemia also can be classified into ECF redistribution of potassium. Here the potassium gets out of the cell to the ECF, or increased total body potassium when there is defective excretion and increased intake of potassium, and the spurious or pseudo hyperkalemia. Let us first start with the extracellular redistribution of potassium. This occurs with acidosis, especially the hyperchloremic, with insulin deficiency, because insulin is important for admitting potassium in the cells. Hypertonicity, like hyperglycemia or mannitol hyperglycemia, of course, without insulin secretion. This occurs because of the drawing of cytosolic fluid by the osmotic activity, with drifting of potassium from inside the cell to outside. Some drugs are famous for producing this transcellular shift of potassium, like beta blockers, cationic amino acid, succinylcholine, and digoxin. Digoxin plays on the sodium potassium ATPase, causing its inhibition. Thus, there is retention of potassium outside the cell and depletion of potassium from inside the cell. And there is a condition called periodic paralysis here, hyperkalemic. Remember, we had a hypokalemic periodic paralysis as causes for hypokalemia. Pseudo-hyperkalemia occur when there is release of potassium outside the body from the cells, like in hemolysis, leukocytosis, thrombocytosis, and exercise and ischemia of the limb during or before drawing the sample. Increased total body potassium occurs rarely with increased intake, but commonly with decreased excretion. Increased intake occurs if it is concomitant with decreased excretion, albeit decreased excretion might be that much, but the combination between some decrease in excretion and massive intake of potassium can cause hyperkalemia, like those taking penicillin potassium, those taking the light medicinal salt, and after transfusion with stored blood when potassium is released from inside the cell to the plasma or the ECF fluid. Decreased excretion occurs with renal failure when the GFR is very low, or in mineralocorticoid deficiency, because mineralocorticoid is very important for potassium excretion through the kidney. And in some intrinsic renal tubular defects of potassium secretion, we call it pseudo-hypoaldosteronism. Mineralocorticoid deficiency occurs in cases like Addison syndrome, which is destruction of the suprarenal cortex by tuberculosis or autoimmune problems. Some drugs like ACE inhibitors, angiotensin converting enzyme inhibitors, or ARBs, non-steroidal anti-inflammatory drugs, heparin and cyclosporin. Hypoaldosteronism without Addison disease occurs in hyporeninemic hypoaldosteronism. This is associated sometimes with prolonged diabetes mellitus or diabetic nephropathy and chronic interstitial nephritis. The hypereninemic hypoaldosteronism occurs due to presence of resistance to the action of aldosterone. So aldosterone is there and renin is increased, but there is resistance to the action of aldosterone. Intrinsic renal tubular defects in potassium secretion, which we call pseudo-hypoaldosteronism, occur in some cases with multiple myeloma, some cases with amyloidosis, some cases with lupus nephritis, some cases with sickle cell disease, and in obstructive uropathy and in renal transplant rejection. So some of these cases are associated with hyperkalemia due to the pseudo-hypoaldosteronism. The signs and symptoms are also here cardiac and neuromuscular. Cardiac, there is ECG changes peculiar to hyperkalemia, and there is cardiac conduction defects, and there can be some arrhythmia causing even VF and cardiac arrest. And it is to be known that cardiac toxicity usually, in many cases, precedes other manifestations. So the patient might come with some discomfort and ECG manifestation, or come with arrhythmia, like bradycardia, or come with cardiac arrest straight away in some cases. The neuromuscular symptoms include tingling, paresthesia, weakness, and even paralysis in some cases. This is a peculiar ECG changes, which is a peak, tall peak T wave here, but later on the patient developed wide QRS complex and the sine wave, then VF and arrest. We manage hyperkalemia according to the presence of ECG changes or the presence or absence of paralysis. If there is ECG changes or paralysis, then we start urgent treatment. And urgent treatment, we give first calcium ampoule. We give 1 to 3 ampoules of 10 milliliter, 10% calcium gluconate intravenous. We can give calcium chloride, but it is irritant to the vein. But we mostly use the calcium gluconate, and it doesn't lower plasma potassium concentration, but it counteracts the cardiac toxicity. It is a temporary measure that works for just some minutes, and then the cardiac manifestations return back again, and you can repeat the calcium once or twice more. The next line is to admit potassium inside the cell quickly by giving something like glucose insulin infusion or sodium bicarbonate or beta stimulant. Actually, if you would like to put them in order, we first start with the beta stimulant, then glucose insulin, and we only reserve the bicarbonate therapy if the patient is in some acidosis. All of these measures are just temporary measures because in few hours the potassium will return back to outside the cell because the cell is already saturated with potassium. So in most of the cases, the condition will return back to the hyperkalemic status and recurrence of ECG manifestation within some hours. So you have to start straight away with some conservative treatment to decrease the total body potassium, like decreasing dietary potassium, like withdrawing offending drugs that cause hyperkalemia, and giving drugs that increase potassium excretion through the kidney, like furosemide, like sodium chloride plus furosemide, like potassium exchange resin, which removes the potassium by excretion through the GIT. And you treat the cause of hyperkalemia if you can identify and treat it. And lastly, if the patient is in renal failure with significant renal failure, then you can start with that. Dialysis is an urgent way of treatment as well because preparing the dialysis machine can take something like half an hour or 1 hour to transfer the patient to dialysis facility. And once the patient is on dialysis machine, the potassium is removed from the body very quickly. So it is a very important step in management of hyperkalemia, especially if the patient has got severe hyperkalemia with renal impairment. Periodic paralysis, as we said here, can be hypokalemic or hyperkalemic, and sometimes it is normokalemic. We call it periodic paralysis. This is the secondary, can be secondary to cytotoxic periodic paralysis with cytotoxicosis, with hyperaldosteronism, with renal tubular acidosis, with villus adenoma, with cocaine binge, with the use of diuretics. These patients will develop the hypokalemic periodic paralysis. The hyperkalemic periodic paralysis secondary is maybe due to hyporeninemic hypoaldosteronism in diabetes mellitus and the renal disease, with intake of oral potassium like medicinal salt in chronic renal failure, in chronic heparin use, and in rhabdomyolysis. And the normokalemic hypokalemia occurs with guanidine, sleep paralysis, TIA, and some conversion. Now let us move into calcium disorders. Here are some causes of hypercalcemia. The most important is neoplastic diseases and primary hyperparathyroidism. Also, we get some in other endocrinal problems that cause hypercalcemia, like hyperthyroidism, acromegaly, pheochromocytoma, acute Addisonian crisis, and tertiary hyperparathyroidism. We've got also some intoxication with vitamin D or vitamin A or with calcium itself, and some granulomatous disease. The most important, most famous is sarcoidosis, but other granulomas can also produce some hypercalcemia, but sarcoidosis is the most famous cause of hypercalcemia. Because the sarcoid granuloma here and the other granuloma can produce something like vitamin D like material that increase the absorption of vitamin D. Malignancy is either solid tumors or neoplastic transformation of hematopoietic cells. There is a condition called familial hypocalciuric hypocalcemia, which is a change in the renal tubules that fails to excrete load of calcium, and then calcium will increase in the ECF and in the patient's body. Another rare condition called pseudo-hyperparathyroidism, when there are manifestations of hyperparathyroidism, but the level of the parathyroid hormone is not increased. Some other causes of hypercalcemia, like immobilization, when calcium leaves the bone, and treatment with certain medications like thiazide, lithium, and theophylline, milk alkali syndrome, excuse me, and recovery phases of acute renal failure, especially after abdominolysis, and there is false hypercalcemia with dehydration. The clinical features of hypercalcemia is usually neurological, but we get some cardiovascular and gastrointestinal as well. The neurological is like lethargy, drowsiness, confusion, coma, emotional lability, depression, cranial pulses, hypotonia, decreased deep tenderness, decreased tendon reflexes. Gastrointestinal manifestation, anorexia, vomiting, constipation, peptic ulceration, acute pancreatitis, and visceral calcification. Cardiac manifestation like arrhythmia, hypertension, or increased digoxin sensitivity or digoxin toxicity. Renal, as I said before, polyuria, polydipsia, and nephrogenic diabetes insipidus. There can be nephrocalcinosis and nephrolithiasis. There can be impairment of glomerular filtration rate. There is other soft tissue calcification, especially the conjunctiva and cornea. There can be red eye, can be pseudogout, and skin with pruritus can be severe, devastating pruritus. So these patients will present with problem in the bones, stones, moans, and groans. Hypocalcemia. The causes are those associated with low or normal plasma phosphates, those associated with high plasma phosphates, and those category of causes associated with hypoalbuminemia. Those associated with hypoalbuminemia is like nephrotic syndrome, hepatic cirrhosis, or protein losing enteropathy, or in cases of hemodilution. Because you know that calcium is in 40% of its component is bound to albumin. So if albumin is decreased, then the total serum calcium or total plasma calcium will decrease as well. But this might not affect the ionized calcium to the same degree, and the ionized calcium might be preserved, so as the symptoms and signs of hypocalcemia, does not appear. Those associated with low or normal plasma phosphate, like vitamin D deficiency, whether it is decreased intake or decreased absorption or decreased generation of endogenous 25 hydroxy vitamin D, or decreased activation by deficiency of alpha 1 alpha hydroxylase, or resistance to the calcitrol itself, like type 2 vitamin D dependent rickets. Cases of acute pancreatitis will engulf the potassium from the ECF, engulfs calcium from the ECF, and in magnesium deficiency, and in a condition called hungry bone syndrome, after prolonged stimulation of bone calcium resorption by prolonged hyperparathyroidism, and then the patient is subjected to treatment of the hyperparathyroidism by surgery. So post-surgically, these patients develop hungry bone syndrome. The bone become very hungry. He eats back its calcium and magnesium and phosphorus, and the patient develops the hungry bone syndrome, which can be fatal sometimes by producing severe hypocalcemia. The other category of causes of hypocalcemia are those associated with high plasma phosphate level. This can be idiopathic or sporadic hypoparathyroidism. Parathyroid hormone is very essential for phosphorus excretion and keeping plasma calcium level, or post-operative after removal of the parathyroid gland, or acquired hypoparathyroidism by irradiation or infiltration of something like amyloidosis, or pseudo hypoparathyroidism type 1 or type 2. Chronic renal failure, when there is retention of phosphate and hypovitaminosis D. And advanced stages of acute renal failure also might be associated with hypocalcemia, hyperphosphatemia, especially in the oliguric states. The clinical manifestations of hypocalcemia are those due to neuromuscular irritability, numbness and tingling, and muscle cramps. So there might be impaired intellectual capacity, depression, and personality changes. There can be seizures, convulsions, respiratory disturbance like laryngospasm and bronchospasm, and the patient might have symptoms of heart failure as well. This is a carpopedal spasm, and this is the chauvistic sign. When you tap on the facial nerve, you get flickering of the orbicularis oculi and the orbicularis oris on the same side. There was deviation of the eye, deviation of the angle of the eye and angle of the mouth, the same side of the tapping. This is chauvistic sign. And this is Trousseau sign when you tighten the cuff of the sphygmomanometer and inflate it to above the systolic reading of the blood pressure by 20 or 30. For 3 minutes, the patient develops carpopedal spasm like that. This is Trousseau sign. Now, lastly is the magnesium disorders. And in magnesium disorder, the causes of hypomagnesemia are either due to decreased intake or increased or GIT diseases causing malabsorption of magnesium, or increased urinary losses of magnesium, or administration of some drugs that increase urinary losses, or some miscellaneous causes like acute pancreatitis, chronic alcoholism, Bartter and Gentleman syndrome, especially Bartter syndrome, acute intermittent porphyria associated with inadequate vasopressin secretion. Idiopathic hypomagnesemia can also occur. The increased urinary losses of magnesium occur with some drug administration, like these drugs, the aminoglycosides, amphotericin B, cisplatin, this anti-malignant drug, cyclosporin, and pentamidine and thiazide diuretics. High urinary output states like polyuric phase of acute renal failure or post-obstructive polyuria, post-transplantation polyuria. Hypercalcemic states can also cause hypomagnesemia due to magnesiuria. Prolonged infusion with excess sodium content. Primary aldosteronism, metabolic acidosis, diabetes is associated with increased renal excretion of potassium, glycosuric and ketoacidotic states especially, hyperthyroidism, phosphate depletion, idiopathic renal wasting of potassium, and Gentleman syndrome. So here we've got Gentleman syndrome increasing renal excretion of magnesium, and Bartter syndrome also as a cause of hypomagnesemia. The manifestations are usually associated with hypokalemia, hypocalcemia, and the metabolic acidosis. There are hyperexcitability like hypocalcemia, and there can be a lot of muscle cramps and muscle pain, and the patient might be lethargic with nausea, vomiting. And if the potassium level is very low, then the patient passes into tremor, hyperactive deep tendon reflexes, hyperactivity to sensory stimuli, muscle fibrillation, and even positive chauvistic and Trousseau signs, and the carpopedal spasm, which might progress to tetany. So the manifestations are just very near to that of hypocalcemia. There is sometimes irritability, disorientation, depression, and psychosis, and there can be reversible respiratory muscle failure in these patients. So the neuromuscular manifestations are multiple, as you see here, and they mostly look like the manifestations of hypocalcemia. On the other hand, hypercalcemia is present with renal failure, whether it's acute or chronic, some cases of severe acromegaly, and in some familial hypocalciuric hypercalcemia, in adrenal insufficiency, and in treating the patient with compound containing magnesium, like administration of magnesium or use of magnesium containing oral purgatives or rectal enemas, or some infant born to mothers treated with magnesium or eclampsia. The symptoms include also CNS problem and GIT problem. CNS problem like lethargy, weakness, and dizziness, and there might be also associated nausea, vomiting, and flushing. Higher level may lead to depressed sensorium and even coma, and cardiopulmonary arrest may occur with extreme level of potassium like those above 10 or 15 milliequivalent per liter. There is loss of deep tendon reflexes, and there are manifestations of CNS depression, and maybe in severe cases, manifestation of respiratory depression and hypopnea. And there can be negative effect on heart rate with bradycardia, SA node suppression, and sometimes there might be AF. And there can be some vasodepression leading to systemic hypotension and even shock in sometimes. This is the end of my lecture, and I'm ready to receive any questions.